Okay, very good morning, everybody. So, today's lecture, that's your last lecture, is on retention and relapse. So, these are the learning outcomes where you should be able to know what retention and relapse means, what can be the various etiologies for your relapse, and what are the various methods of retention, types of retention devices, and also theories of retention. So, this is how a patient comes to you for treatment. So this is the pre-treatment with lower anterior crowding, and you've done some serial extraction, and that's your final well-aligned lower anteriors as your post-treatment result. But what you see is maybe after 1 year, the patient is back with minimal lower anterior crowding. So this loss of correction achieved through an orthodontic appliance is what is termed as relapse. That means your retention was not good enough to prevent the relapse. So there can be various destabilizing factors, that means factors which have destabilized your final corrected occlusion post orthodontic treatment, which has led to a relapse happening. That means teeth moving back to their original position, like the stretch of the adjacent periodontal and gingival fibers tightly hugging the teeth, which made sure that the teeth come back to their original position. Or it could be an existing orofacial soft tissue, the habit or the soft tissue was not relaxed, a lip sucking habit, which made sure that the teeth come back to their original position. Or it can be that the occlusion that you brought about post treatment was not well settled. Remember, my friends, if you have an occlusion like this with upper and lower arch inclines fitting completely, interdigitating properly, then there is no sliding or gliding along the cuspal inclines possible, and hence it aids in retention. However, if your occlusion is not proper, there are chances that this particular premolar, it can slide here or mesially or distally, either ways, and hence there are very high chances of relapse happening. Apart from that, one of the important factors which needs to be considered is your post-treatment facial growth. So timing of your treatment is extremely important, and depending upon that, you need to plan which retention appliance is required for your patient. Suppose this patient comes, and this is the post treatment of the patient. The patient has come for treatment pretty early, and I have not taken a family history, so I didn't know that the mandible had a good growth, and maybe her mother was class 3 as well. So how it can go wrong is, with time the patient's mandible kept expressing growth, because mandibular growth is the last growth to take place, and maybe 10 years following the orthodontic treatment is over, the patient develops to be a class 3. So that is a failure as a part of as an orthodontist from my part, of not having recorded the family history of a patient. My timing of treatment should have been different, or I should have given adequate retention appliance to make sure that the mandible does not continue to grow in this fashion. So just have a look at this video of
Over
how to
time, thumb
sucking.
sucking can have a dramatic impact on the alignment of teeth. A thumb habit appliance can help break this habit. The appliance makes it impossible to create suction, which is where the feeling of satisfaction comes from. Once the habit is broken, the teeth will start to return to their natural position.
Okay, so just like this thumb sucking habit is capable of moving your teeth abnormally and causing a malocclusion, it if the habit still persists and you did not point it out, you were not able to find out the main cause of the malocclusion, you corrected the teeth, made them come back to the normal position post orthodontics, and you didn't realize that patient actually had a habit which had led to the same, and the habit still persists, then the same changes will be brought about yet again, and your orthodontic treatment is going to fail. Hence, case history recording, etiology finding out is extremely important, and it is a part of treatment. think it's playing the same again. Okay. Another component is your role of anterior component of force. All the forces which are acting in your oral cavity, that means your masticatory forces being one of the heaviest of all, are all inclined mesially or anteriorly towards the midline. Hence, post your orthodontic treatment also, all the forces will be acting in that direction. So most of them will lead to a relapse in the form of lower anterior crowding, because all the forces are acting towards the midline. It is actually said analogous to the billiard ball analogy. It says that if you're aiming the ball at that point, so despite of you aiming at whichever direction, it will always have a force which is making it go in front. So it will have two force vectors, but ultimately a mesial or an anterior directive force will always be persisting. So whenever you are chewing, all the forces from the molars are actually being directed towards the midline. So this
Mesial
is
drift
termed
is the
as
natural tendency for the teeth to move towards the front of the mouth, in effect, towards the lips. Teeth do tend to move towards the front. This makes sense because chewing movements lead to torsions of the lower jaw and to deflections of the teeth in the tooth sockets themselves, causing friction on the teeth's contact points. Friction, of course, means wear, and the teeth grind each other down at their contact points. If the teeth didn't naturally want to move towards the front, one would eventually develop gaps between the teeth. However, in places where a tooth is missing, a typical consequence is that the teeth will tilt into the existing gap due to the mesial drift. This changes the bite plane. In effect, it sinks, meaning that the support of the lower jaw no longer takes place on the surfaces of the teeth, but primarily in the jaw joint itself. In most cases, the jaw joint will adapt accordingly, and osseous reorganization processes occur.
okay, we'll not go into detail of what various effects it can cause, but what is important for us to know as an orthodontist is that this is something unavoidable. This is a natural tendency, and that's why we see lower anterior crowding relapsing. So in few, this mesial drift will be more, in few it can be contained. So that is a luck factor for us. So there are various schools of retention, as in there are various authors which have said that if you achieve this post-treatment, then there are chances that you will be able to retain the corrected results and there'll be no relapse. So the first of all is the occlusal school by Kingsley, who says that if you get a perfect interdigitation of your posteriors, then there'll be no glide along the cuspal inclines and you'll have a perfect retained occlusion. Then you have the apical base school, which says that if you maintain the width of your apical base, the bony base on which the dentition is present, especially your intercanine and intermolar width, if you don't change and meddle with it much, then your results are going to be stable. Then you have a musculature school, which relies on your buccinator mechanism or the equilibrium theory, which says that if you position the teeth well in the neutral zone where forces acting buccally on them, that means your cheek and the lips, and the forces acting lingually, that means the tongue, are in balance, if they are somehow equal, of course along with the active stabilization being performed by the periodontium, then your teeth will stay where they are. Then you have your mandibular incisor school by Charles Tweed. I think we all know about it by now because of your preclinical exercises and the lecture on cephalometrics which has been taken already. So this is your Tweed diagnostic triangle, and you have your three planes which I expect all of you know. And so if your lower incisor to mandibular plane angle is 90 degrees, Tweed says that the results obtained will be stable and there'll be no relapse. Now this is the very important aspect of this particular lecture. These are Riedl's theorems of retention. Remember, these are certain theorems which have to be kept in mind when you're planning treatment and giving retention to a particular case. And the important point is you have to memorize them word to word. So when you are writing it in your answer, you are not allowed to change the words also. So your theorem 1 says, so I'll try to I'll help you memorize them by quoting an example. So suppose you have a fat lady who wants to reduce weight like this. So what is the first thing that should come into your mind? That of course she is going to gain some amount of weight, right? It's not that it's going to remain stable completely. That never happens. That's a common thing which most of us would have experienced in our life. So there is very high tendency that some amount of weight gain will definitely happen. So the first theorem is a reality check that teeth that have been moved tend to return to their former position. So we cannot expect a 100% retention rate in any case. That's the harsh reality. So that's our first theorem, and what I want you to realize for all the theorems is you are not allowed to change the language, so you have to memorize it exactly the way it has been quoted. Okay, teeth that have been moved tend to return to their former positions. So we move on to theorem 2. So you have the same lady and she's lost weight, very good, but what if she continues to eat? Then again, she is going to gain weight. There is going to be no retention. A relapse will happen and she is going to move back to the former position. Why? Because the main cause, the etiology, that is the food, has not been eliminated. So it points out to the fact that the elimination of the causes of a malocclusion should aid in the retention of its correction. So basically, the etiology needs to be eliminated for you to avoid relapse. So next we move on to the orthodontic example of the same. So suppose this is the post-treatment. I have well-aligned anteriors and I ignored the cause of a pre-treatment midline diastema which was existing because of this penetrating papillary penetrating frenum type. So what is going to happen? It is definitely going to lead to a relapse with the midline diastema reappearing over time. So the cause is that I need to remove this and now close the remaining space. So we remove this frenum almost at this stage where just 1 mm of gap is left and then we close that space. So we need to remove the etiology. So we move on to theorem 3. So yes, so I know most of you cannot believe that this is the same lady, and I'm sorry I could not get the picture of the same lady, but the idea is I'm trying to emphasize, since we know according to theorem 1 that relapse is going to happen and the lady is going to gain weight, it is a good idea that she overdoes it. Okay, so she literally starves and becomes the way she looks currently at this stage. So the idea is, since you know relapse is going to take place, you should always go ahead with overcorrection. So your theorem 3 says overcorrection of a malocclusion is a safety factor in retention. I'm not talking about how practical it will be, especially in terms of weight loss. I don't think it's very practical. But yes, in orthodontics, we do practice that, especially in terms of things which are very, very prone to relapse, like our rotation correction. So suppose I have a tooth which is severely rotated, it is always a good idea that I do a overcorrection. So that's my pre-treatment. You can concentrate on this pink bleb over here, and suppose that's my goal. So what will I do? I will go beyond the goal. That means I'm going to overcorrect it and actually end up rotating the tooth in the opposite direction slightly and expect that it is going to relapse and finally post retention be stable and become my goal. So we move on to theorem 4. So this is actually very, very practical, I must say. So a girl is dieting and now she's going to make sure that the husband or the boyfriend also diets along. So how will that help? So when both lower arch being the boy, upper arch being the girl are dieting together, the results are going to be stable because both are going to refrain each other from eating and they'll act as an encouraging factor and they will not let any gliding or slipping of the commitment taking place. So it's just like your upper and lower arch staying together, committed with no cuspal inclines, and you end up in a perfect occlusion. You don't let each other move. So occlusion is an important factor in retention. This also goes in line with one of the schools of retention which I told you, where occlusion has been given special emphasis, which makes a lot of sense, especially for the posteriors. So we move on to theorem 5. Theorem 5 says, of course, ultimately we have to make sure that the things are harmonized well. And it's not just that she gives up food completely. She has to get it replaced and give enough time that her diet pattern itself is changed. She cannot be starving, right? So we have to give enough time for the bone and adjacent tissue to reorganize around the newly positioned teeth, and only when the teeth are stable in that new position, then you remove the appliance. Meaning, if you are treating the case in too less a period of time, then also there are high chances of relapse happening. You have to make sure that you've given enough time for the surrounding tissue to adapt to the new position of the teeth, or else you increase the duration of your retention. Theorem 6 is something we already know. So don't overdo it to the extent that things are not stable. You have to do everything according to your capacity. That means according to your bone type. The inclination of the lower incisors cannot go beyond being 90 degrees. So you have to make sure that everything is in harmonious relationship with the bone. Bone is your ultimate capacity. If bone is not there, you cannot move your teeth beyond the bone. Okay, so this goes in line with your Tweed's retention school also. So we move on to theorem 7. So the best thing would be, remember, any habit which is inculcated right from childhood in you stays in you lifelong, and it can act like an interceptive or preventive orthodontics, and your duration of treatment will be less. So if these girl and boy I'm talking about who are finding it so difficult to lose weight and they have to do overcorrection and literally starve to make sure no relapse happens, if they would have been told the right eating habits right from the beginning, right from childhood, then probably this much of hassle would not have been created. So the basic idea is that corrections carried out during period of growth are less likely to relapse. So your theorem 7 is actually telling that you do treatment during growth period. That's why it's said to be a good idea. It's actually easier also to do treatment when the growth is still present. Adult orthodontics is a difficult and a challenging braces treatment for both the orthodontist and the patient himself. So this is also advocating you to go ahead with interceptive and preventive orthodontic treatment rather than corrective and surgical orthodontic treatment. So we move on to theorem 8. So we have our starving lady yet again. So this is actually, you can say, the jumbling of words for the same theorem I have already covered in theorem 3, which is reinforcing about overcorrection. So this is just jumbled up again, and it says that further the teeth have been moved, the less the likelihood of relapse. So again, in the terms of orthodontics, I am talking about rotation correction. So I am actually going to rotate the tooth in the opposite direction, fearing relapse. So we move on to theorem 9. So I'm also reinforcing here the boy being synonymous to the mandibular arch, who are supposed to be very, very stringent. They do not listen to anybody. So that's how a mandibular arch also behaves. So it's said to be a fact that if you meddle with the mandibular arch, there are very, very high chances of relapse happening. So normally whatever things we do are mostly with the maxillary arch. That's why we are expanding the maxilla. We are not expanding the mandible, because mandible is something which is very, very, it's just like boys basically. Yeah, so theorem 9 says arch form, particularly in the mandibular arch, cannot be permanently altered by appliance therapy. If you do that, there are very high chances of relapse happening. So be careful when you have a mandibular arch like that. Maybe you can treat that by expansion in the maxillary arch, Mandibular, you do like that, you change the arch form, make it so wide, there are very high chances of relapse happening. So we move on to the last theorem, 10. So you find out who has given this theorem. There is a little twist here. It might be asked in your quiz also, which will be followed after this last lecture of yours. So again, I'm showing the female and the male again. So I'm talking about many treated malocclusions require permanent retaining device. So which malocclusion am I talking about? Of course, the mandibular arch. Anything you do with the mandibular arch, you need a permanent coaxing and cajoling, just like this couple you can see. So basically you need a lingually bonded retainer in the mandibular arch. That's why you will see invariably in most of the orthodontic cases, we will place a permanent lingual bonded retainer canine to canine in the mandibular arch, because there are very high chances that any corrections that we do in the mandibular arch are going to come back to normal. And hence we place this retainer which is supposed to be there lifelong. Hence it is called a permanent retention. Apart from this, there are some Raleigh-William keys which have been given to enhance the retention, and this actually relates to your incisors in canines, inclination and angulations. So the key one actually tells you about the mesiodistal angulation of your lower incisors, how you should end up post treatment to get maximum results. So there are 3 ways you can have your lower anteriors. That's how it looks like. So the basic idea is we want enough bone to be present between the roots so that the newly attained position is stable enough. So out of these 3 pictures, of course it is the last picture. That means we want the lower incisor roots to be slightly distally placed so that you have enough bone to readjust, to readapt to the new position. So that's one of the keys of having best retention and minimal relapse. Key 2 talks about the labiolingual position of your lower incisors in relation to A to pogonion line. So your lower incisal edge should exactly be in line with this A pogonion line, or maybe just 1 mm here and there, not more than that. Your key 3 talks about the canine. So it emphasizes that the crown tip has to be slightly mesial or towards the midline, whereas the root is pointing slightly distal or towards the condyle. Key 4 says that if you look from top occlusal view, all your incisors should be in the same labiolingual plane. So the entire root and the crown are in the same line. You should not be able to see the root flaring in front or inside. No labial or lingual movement of the crown. So they are exactly straight, standing straight. Key 5 goes back to the canine, where it is also highlighting that the lower cuspid root apex must be positioned slightly in front of the crown. So this is unlike of key 4. So incisors are straight, whereas for canines the crown tip is slightly inside, whereas the root is slightly outside. So it is tilting inwards, your canine. Key 6 is very important. It says that you should slenderize, that means do proximal stripping of your lower anteriors just before debonding the case. So that makes a lot of sense, because if you see, this is the post-treatment suppose, where you have your incisors well aligned, but normally because of the shape of the incisors, you are going to have a point contact between the incisors. Since it's a point contact, there are very high chances that they can slip past each other. If you want more retention, it is always advisable that you increase the contact area and convert these contact points into contact areas instead. So if you do slenderization or proximal contact, breaking of these incisors just before removal of your appliance, your contact area increases. It flattens your contact points and converts them into contact areas, and hence makes your result much more stable. So depending upon the duration of retention, there are certain malocclusions. So remember, when we are planning for retention, we are going to remember the pre-treatment malocclusion of the patient, and depending upon that, we give a retention to the patient. So there are certain malocclusions which do not require retention at all, so which are best cases to be treated by orthodontics with no relapse at all. There are few which require retention for some time, maybe 2 years, and there are few which require a permanent retention, lifelong retention, where we are going to place those lingual bonded retainers in the patient's mouth. So the malocclusions which do not require any retention are of course those carried out during growth period, and your cross bites, be it anterior or posterior, because once you correct and get a positive overjet, it is a self-retaining malocclusion. And your serial extraction cases and even a buccally placed canine, once you get that correctly into position, they generally do not go back and no retention is required at all. Then there are few which require limited retention. These are most common of the cases that we encounter in our practice. So these can be a simple class 1 cases which are treated by non-extraction, or it can be class 1 or class 2 cases treated with all 4 extraction with just maybe proclination post-treatment and not much of imbrications, crowdings or spacing present. Now the malocclusions which require permanent retention, so you tell that to the patient when you are starting the treatment itself that you will need one wire or some other permanent retention type lifelong. So they cannot blame it on you that they removed this, they did not follow the retention and things have gone back. So of course your midline diastema is very prone for definitely requires a permanent retention. Your class 2 division 2 malocclusion, then severely rotated incisors, very prone to relapse. Cleft lip palate patients where you've undergone expansions, and the etiology has not been removed, and of course your mandibular arch form changing is going to need a permanent retainer. So now since we are planning for retention, we should also know the types of retainers which are available. So there can be retainers which can be removed by the patient himself, but of course we need compliance for the same. Then there will be certain retainers which are going to be fixed, which the patient will not be able to remove. And then there will be active retainers. Remember, retainers are supposed to be ideally passive appliances. They are not supposed to apply any force. They are just supposed to maintain the position of the newly moved teeth. So the third type of retainer here is a little controversial and I'm not very much for it. Maybe it can be given once there's been a little relapse, or you have not been able to complete and brought about the complete results and had to do a premature removal of the appliance, but I'm not very much for it. But anyways, I'll show you a video of how it really works. So we move on to removable and fixed retainers. So look at the video, the patient's treatment is almost getting over and we just remove the appliance. We are going to remove the braces now. Okay, so we remove the braces, and this is one of the commonest type of retainer, or Hawley's appliance with a label bow and Adam's clasp on the molars. You can give it an upper and lower. You can even give a beg retainer with the beg label bow instead. So both these are the simplest of the removable appliances. Or if a patient is very conscious about the label bow also being seen, because the patient is very excited and he doesn't want any braces or any mark of that being seen in the pictures, then you can give a VFR, a vacuum formed retainer, like this, and again give it to the patient. So this is a removable retainer where the patient can remove him or herself, and you need to give a box along with that. There'll be instructions, maybe 1 year full time followed by 6 months just nighttime wear, taper it down, and finally no retention. So apart from that, if there are malocclusions which require permanent retention, then you need to put a fixed retainer. So after etching the teeth, you're going to apply bonding agent or primer on the lingually on the anterior surface. You adapt a wire, it can be stainless steel or ligature, Australian wire, and then you are putting composite, a light cure composite, adapting nicely onto each tooth. This is to secure the wire where it is, and it's going to stay there lifelong. And then you cure it with your light cure unit. So that's your permanent lingual bonded retainer, very common. Of course, you can give it an upper arch also if there's been crowding or midline diastema. That means any malocclusion which requires permanent retention would need that. So next we move on to what I was talking about, active retainers. So this is just one of the advertisements I've taken in man aligners. So this aligner, they claim that is going to bring about some movement also, apart from retaining the changes which have been already achieved. So it's actually working like braces along with retention. It doesn't look very practical to me, but you can have a look. So they are showing a patient like this with some malocclusion, actually a lot of malocclusion according to me still left, but probably they had to debond the appliance and maybe the periodontium did not allow and they wanted a removable appliance with lighter force to cause the remaining tooth movement. So whatever the cause might be, so these retainers are also bringing about certain tooth movements. So you can see in the lower, it's going to apply selective pressure surprisingly and move the teeth. It's pushed the lower anteriors in front and moved and got them aligned. So it's retention along with movement. So active retainers. Yeah. So next I will tell you certain malocclusions, as I told, will require, it's a good idea that you give retention. So like class 2 and class 3 patients. So in patients who are class 3, so this is of course how you treat it by a Frankel 3 appliance. Remember, myofunctional appliance which you give, where you have lip pads in the upper arch, which is going to make sure that the upper restraining factors like the lips and the cheek muscles stay away from the maxilla and the maxilla is allowed to grow, and there is a restraining factor, that means a lower labial bow which will not let the mandible express its growth to the fullest. It's always a good idea that we can give this appliance as a retention also till we feel that most of the mandibular growth is left. Otherwise we are going to end up with having a relapse of a patient from class 3 to class 1 and later allowing the residual mandibular growth to express and the patient coming back to a class 3. So it's a good idea to prolong your treatment and give this Frankel 3 appliance as your retaining appliance, and same goes for your class 2 malocclusion also, which we generally treat by pulling the maxilla up and behind by giving a high pull head care. So this you would have read in your orthopedic appliances already. So it's a good idea that if you're fearing that the mandible might not be able to express its full growth potential, or the maxilla is still growing and you're doubting that it's going to overpass the normal growth and the patient will become class 2 again, so a lot of growth is still left depending upon the skeletal maturity indicator, it is a good idea that you continue the high pull headgear till you feel the maxilla is dangerous and can bounce back to the normal growth pattern. Similarly, malocclusions like deep bite is also a controversy. Just like we can treat deep bite by adding an anterior extra acrylic on this Hawley's appliance. It's called an anterior bite plane, right? Same way we can add it in our retainers, Hawley's appliance or our beg retainer. So this extra acrylic posterior to the upper anteriors is going to lead to a posterior disocclusion, enabling extrusion of the posteriors and correcting your deep bite, or maybe over correcting your deep bite if it is given in the form of a retainer post treatment. Similarly, your open bite is also very prone to relapse. So just like you can correct it by giving posterior bite blocks leading to intrusive force acting on your posteriors and correcting it, same way you can incorporate it as a part of your retainers and make sure that you overcorrect or retain your corrected results. And of course, rotation correction, as I told you, your periodontal and the gingival fibers are very prone to relapse. So probably when a tooth is rotated more than 90 degrees of what it should be, then it's a good idea that you cut those gingival fibers around it by extending the scalpel about 1 to 2 mm into the gingival crevice and just cut those fibers so that their elastic recoil cannot pull them back into their original position and cause any relapse. So this is called as your periscission or circumferential supracrustal fibrotomy. I'm hoping that it has already been covered in your surgical orthodontics. So it's not just surgical orthodontics, it is also a part of your retention. So next, your frenectomy, which is also a minor oral surgical, minor orthodontic surgical procedure. It is also always a good idea that you, if at all, find out a papillary penetrating nature of this frenum type, it is a good idea that you cut this frenum just before debonding your appliance if you want to make sure that the results you have achieved should stay the way they are and there should be no relapse, because it's like the etiology of the midline diastema. If you do not remove this etiology, the relapse will definitely happen. So I know it was a little long lecture, so the few who have not slept, please keep it up, and the rest wake up for now. So thank you everybody. This was the last lecture. I hope your concepts are clear. Please feel free if you have any queries, not just regarding this lecture but of the previous lectures as well. And yes, be ready for a short quiz following this. Keep reading and stay safe. Bye bye everybody.